Bismillahirrahmanirrahim. Assalamu alaikum. This is Kiran Root, a student of 4th year morning, wearing roll number BB1550090. I am the member of group number 8, and the topic which we have assigned is pain and its management, of which my subtopic is headaches. Prior moving towards the case which is to be studied, we should know the basic details of headaches, their sites, their localization, where they are located, and uh, the causes. So, starting with the what is headache? Headache is a symptom that can be caused by many disorders. For example, head pain can result from traction, displacement, or dilation, which is the inflammation of pain sensitive structures within the head, or it can be due to disorders of extracranial structures such as eyes, ears, or sinuses. In how many categories the headaches is divided? So the headache is divided into two categories, of which one is primary headaches and the other is secondary headaches. Primary headaches are characterized by lack of an identifiable and treatable underlying cause, which are of three types: migraine headaches, tension type headaches, and cluster headaches. These headaches could also be called as vascular headaches. And secondary headaches are associated with a variety of organic causes such as trauma, cerebrovascular malformations, and brain tumors. Depending on the cause, headache may manifest in a variety of ways or may be accompanied by other associated signs and symptoms. The sites or locations of the headaches are shown in this diagram. The headache is majorly of four types, which the patients usually or majorly claim. The first one is sinus headaches, the second is cluster headache, and the third one is tension type headache, and the last one is migraine headache. So the site of sinus headache is paranasal. Means the pain is usually behind the forehead or cheekbones. The cluster headache, it is ocular. The pain is in or around one eye. Tension type headache is like a band. That means the pain is like a band squeezing the head, and the migraines are usually unilateral. The pain, nausea, and visual changes are typical of classic form of migraines. Now the causes of headaches. The factors which cause the headaches include stress, which are emotional stress, depression, or skipping meals. Environmental factors such as tobacco smoke, perfume odors, allergens, etc. Illness, which is a major cause of headache, include cold, fever, throat infection. It is it is genetically transferred also, means headaches, especially migraines, uh, are genetically transferred from the family. If the family history is if there is migraine in the family history, then it may consider as a genetic factor. And overuse of medication like NSAIDs and caffeine result in severe headaches and cause rebound headache. Rebound headache is actually the overuse of medication. Adequate evaluation of headaches. Headaches must be accurately evaluated and classified because these symptoms may reflect an ominous problem, that is, the threatening problem, such as the presence of a brain tumor or a much more benign process, such as muscle tension. Moreover, effective intervention depends on a correct diagnosis. When a patient should visit a physician, usually occasional headaches are common and can be life-threatening, so we could not how we should not uh, take for granted. We should not take them for granted. If the frequency of headache starts to increase and pain threshold maximizes, then immediately consult a physician. Now, coming towards our case, MK, a 32-year-old man, is complaining of severe headaches that occur at least once every 2 weeks. He takes two Excedrin extra strength tablets, which is a combination of acetaminophen 250 mg, aspirin 250 mg, and caffeine 65 milligrams every 2 hours until the headache starts to ease, and sometimes requires a cumulative dose of up to 16 tablets, which is not a recommended dose. It is actually the double of the recommended dose. Migraine and vascular headaches have been ruled out in MK. Would one of the non-salicylic NSAIDs be more efficacious for MK? Are there any other considerations in managing MK's headache? Is caffeine effective analgesic for headaches? So, we will start our case study making the SOAP notes, which include subjective, objective, assessment, and our plan. Subjective includes chief complaint, which is severe headaches. The patient name is MK, gender is male, age is 32 years, and the frequency of headache is once in 2 weeks. What is the objective? He takes two Excedrin extra strength tablets, which is a combination of acetaminophen 250 milligrams, aspirin 250 milligrams, caffeine 65 milligrams, every 2 hours until the headache starts to ease. Sometimes he requires a cumulative dose of up to 16 tablets. Migraine and vascular headaches have been ruled out in MK. These, these are our objectives on which our assessment and plan based. Actually, the assessment and plan is based on both subjective and objective, but these are under new consideration. Assessment for MK, who self-medicates chronically with large doses of acetaminophen, the concern is toxicity of analgesics. Chronic use of both NSAID analgesics and caffeine, either as single agents or in combination, can possibly precipitate withdrawal headaches, which are also termed as rebound or headaches, on the discontinuation of medication. Although NSAIDs are not considered habituating, accumulating evidence indicates that chronic intake of peripheral acting analgesics can perpetuate the underlying pain of the syndrome. In the case of MK, it is important to consider the possibility of caffeine withdrawal headache as well, because he is taking a caffeine containing combination product, which is Excedrin. Other dietary sources of caffeine ingestion from coffee, tea, and other foods should be determined as well. What should be our plan? Our pharmacological plan or treatment should include: for the pain relief, the recommended doses of Excedrin should be taken with recommended frequencies of to overcome toxicity and rebound headaches. Means 2 Excedrin extra strength tablets per oral thrice a day or 4 times a day. MK's headaches may resolve on gradual withdrawal of NSAID analgesics and caffeine, but this process is slow and requires the clinician's and as well as the patient's determination to stay with the treatment plan. So this is a little bit slow treatment plan, but it is the most effective for the rebound headaches. Now, the non-pharmacological plan includes how the person should get enough sleep, he should not skip meals, exercise regularly, reduce stress, reduce intake of caffeine. Now, what one of the Would one of the non-salicylic acids be more efficacious for MK? Yes, because non-salicylic acids also have anti-inflammatory actions and can reduce headaches, and they do not contain caffeine. As migraine and vascular headaches have been ruled out in MK, so this medication could be efficacious in MK. Are there any other considerations in managing MK's headache? No, there should not be any other considerations because his headache can be reduced by weaning the medication or by gradually decreasing the medication needs. Is caffeine an effective analgesic for headaches? Caffeine itself is not an analgesic and causes cerebral vasoconstriction, which decreases the blood flow and oxygen tension. However, in combination with acetaminophen, caffeine may provide a quicker onset of action and enhance pain relief, allowing for lower doses of analgesics. So, this is all. Thank you.